Hello everyone, and welcome to today's webinar series on bleeding and clotting disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also commonly known as the CDC. I'm Christopher Bean. I am a researcher and current acting branch chief in the laboratory at the Division of Blood Disorders here at CDC. I'm very pleased to be with you today for our presentation on laboratory testing for von Willebrand disease. I'll be serving as today's moderator, and at this point, I would just like to especially recognize the Hemophilia Federation of America for hosting our webinar. So before we get started with the main event, I've been asked to remind everyone of a few webinar points and helpful hints. A webinar, as you know, is just like having an in-person conference, except from the comfort of your own home or office or wherever you may be in this mobile world. Upon joining the webinar, you should have seen two audio options: to listen via the speakers on your computer or by using your phone to call in. If you chose the phone, the webinar toolbar should have provided you with a phone and access number and audio PIN. Now, because of the very large number of participants attending today's webinar, all the incoming audio from the audience will be muted. However, at the end of our presentation, there will be time for questions. So to submit a written question for Dr. Miller, please just use the questions area of your toolbar, and she will respond to as many as time allows. Today's webinar is scheduled to last approximately 1 hour. And finally, I'd just like to remind everyone that this webinar will be recorded and made available, so please also assist us in minimizing extra background noise. Now, with that out of the way, it's my great pleasure to introduce our guest presenter, Dr. Connie Miller. Dr. Miller is a medical geneticist, and she directs the Clinical Coagulation Laboratory for the Division of Blood Disorders here at CDC. Dr. Miller has spent more than 20 years in clinical care for people with hemophilia, and she's been recognized both nationally and internationally for her work in laboratory methods for use in inhibitor testing. So without any further ado, Dr. Miller, please begin.
Thank you, Chris. Before we begin, we would like to take a brief poll to find out what our audience is. So I would like to ask you to please respond to the poll that you will see on your screen and tell us about yourself. We have several choices for you to determine who our audience is today. And the results from the poll will appear so that that you can also see who is tuned in. So we thank you for your participation. And I'd like to welcome all of you today, and as Chris said, the presentation will be archived so that you will have access to it later because there is additional information on some of the slides that you might like to refer to. Also, we will be providing my contact information at the end so that you can contact me directly with additional questions after the webinar is over. But we will provide time for questions at the end. Okay, now we have poll results showing that we have 22% physicians, 7% people from the bleeding disorders community, 13% from industry, looks like 9% from labs, and 48%, the majority, are other healthcare providers. So many of you are working in the healthcare field, and we will try to gear our presentation so that all of you can benefit from it. And thank you for sharing this information with us. I'm going to talk about the diagnosis of von Willebrand's disease, the challenges and opportunities that this presents. Firstly, what is von Willebrand's disease? It has a scary name. People often don't like to refer to it. Von Willebrand's disease is a bleeding disorder that is due to a defect or deficiency of the plasma glycoprotein that has come to be called von Willebrand factor, or VWF. It's the most common inherited bleeding disorder and may affect as many as 1% of the population. It is a bleeding disorder that affects both men and women. and it affects both primary and secondary hemostasis by impacting both the coagulation pathway and platelet function. And it has been called the biggest diagnostic challenge in hematology. So we have a lot of material to cover to try to help you understand how this diagnosis is made. The disorder was first described in 1926 by Erik von Willebrand, who was a Finnish physician. He vacationed on the Åland Islands off the coast of Finland, and he found there a family with a young girl who bled to death after her fourth menstrual period. Other family members were both severely and mildly affected, and he recognized that this was different from hemophilia because females were affected in the majority in this particular family. And also there was no test of bleeding that was abnormal at that time except a skin bleeding time, which was normal in hemophilia. In 1952, it was found that patients with von Willebrand's disease were also deficient in factor VIII, the factor that had just been found to be deficient in classical hemophilia or hemophilia A. And that has linked the two disorders together in both diagnosis and treatment. In 1972, Ted Zimmerman described the protein that's deficient in von Willebrand's disease, and he called it factor VIII-related antigen. Although at that point it was recognized that the proteins were probably different, factor VIII and von Willebrand factor, it wasn't until the 1980s when the genes were separately cloned that it was proven totally that there were two different gene products. The von Willebrand factor gene is located on chromosome 12, and it makes a subunit that is recognized as von Willebrand factor antigen, while the gene for factor VIII is on the X chromosome, as we know from the inheritance pattern of hemophilia. It is bound to the von Willebrand factor antigen and carried in the circulation by the components. The components of von Willebrand factor aggregate into large multimers, and when there are enough multimers present, von Willebrand factor activity is there. The von Willebrand factor gene is very large as the one for factor VIII, which makes it a challenge to study. The protein has 2,813 amino acids, and it cleaves first a signal peptide that's removed, and then a larger piece called the propeptide that's removed during processing. The domains of von Willebrand factor include binding regions for factor VIII, for glycoprotein 1b, for collagen, and for GP2B3A in different parts of the molecule. And if we look at the cDNA, which is very large, there are mutations throughout the length of the molecule that cause different types of von Willebrand's disease. Von Willebrand factor is synthesized in endothelial cells and megakaryocytes, and then it becomes located in the plasma, the Weibel-Palade bodies of the endothelial cells, the subendothelium, and the alpha granules of platelets. So it is a very widespread protein. In addition to its function in carrying factor VIII and localizing it at the point of vessel injury, von Willebrand factor binds to the subendothelium where collagen is exposed, and then links to the GP1B binding site on platelets to provide platelet adhesion. This binding induces the GP2B3A expression, and then acting through that receptor, von Willebrand factor binds platelet to platelet. And these functions perform in vivo in a high shear flow situation, which is very difficult to duplicate in vitro for laboratory testing. The pathophysiology of von Willebrand's disease is complex. It includes both quantitative and qualitative defects that I'll describe. The mechanisms of defects are varied, with both decreased synthesis of von Willebrand factor and increased clearance, and some mutations presenting a combination of both mechanisms. While many von Willebrand disease types can be designated as being located in the structural gene on chromosome 12 for von Willebrand factor, There are mutations in type 1 von Willebrand's disease that do not appear to segregate with the chromosome 12 gene, and there must be other genes involved in determining von Willebrand's disease in some families. There are modifiers that make this a more complex situation that include the ABO blood group and race. The quantitative defects in von Willebrand factor are of two types, based on the number of abnormal alleles that are present at the gene site. Type 1 disease has structurally normal von Willebrand factor that is reduced in quantity, and it may be due to decreased synthesis, increased clearance, or a combination of both. And these people are usually heterozygous, having just inherited an allele from von Willebrand's disease from one parent. If two alleles are present from both parents, then a severe type 1 patient can be produced. Type 3 is virtual absence of von Willebrand factor or only traces there. And that is usually the presence of two alleles, which can be homozygous or compound heterozygous genetically. The qualitative defects in von Willebrand factor are classified as type 2 defects, and there are a variety of those, divided by whether their multimer structure, the structure of their protein is normal or abnormal, and also how their function is. The type 2A is a loss of function, von Willebrand factor function, with the presence of abnormal multimers, while a type 2B is a gain of function, an increased function of von Willebrand factor with also abnormal multimers. Type 2M has been described as having a loss of function but with the presence of normal multimers. And type 2N has a defect only in the factor VIII binding site of von Willebrand factor, with all other aspects of von Willebrand factor being normal. We have recently looked at the frequency of von Willebrand's disease types in over 12,000 von Willebrand's patients that have been accrued into the population profile portion of community counts, the national surveillance programs conducted by CDC in Athens. And you can see that from the graph that the vast majority of patients with von Willebrand's disease have type 1. There are 86% of those with type 1 disease. And other subtypes make up smaller amounts, from 1 to 5% of the group. So when we're trying to diagnose von Willebrand's disease and distinguish all of these subtypes, for many of the patients involved, that's not relevant. They have type 1, and whether there are other subtypes is not relevant to their particular experience and their particular treatment. So I think we have to keep that in mind as we focus our efforts on diagnosis and treatment, that we're dealing with small numbers of patients with rare disorders and a large group of patients with a very common disorder. The components of the diagnosis of von Willebrand's disease include a personal history of bleeding, a family history of bleeding, and the laboratory findings, and all have to be considered. The symptoms of von Willebrand's disease in the typical patient are mucosal and cutaneous bleeding with frequently epistaxis, bruising, menorrhagia, and GI bleeding. There may be dental, postpartum, and surgical bleeding, and hemarthrosis and muscle bleeding are uncommon in typical von Willebrand's disease patient. In severe von Willebrand's disease, however, the mucosal and cutaneous bleeding is present but is much more severe, and these patients may develop hemarthroses and muscle bleeds similar to those seen in hemophilia. They may also develop inhibitors that act against factor VIII and von Willebrand factor. Clues to the diagnosis of von Willebrand's disease and the symptomatology are a lifelong history of bleeding, not a history that has just occurred recently. Nosebleeds lifelong, which often lessen at puberty, and heavy menstrual bleeding from the start of menstrual periods at menarche. Bleeding scores have been advocated for use in diagnosis of von Willebrand's disease to evaluate symptoms, and there are tools available on the ISTH website for bleeding scores, specifically one tool for type 1 von Willebrand's disease, that may aid people in taking histories that are appropriate to cover all the bases when we're trying to make this diagnosis. There are also some newer applications that are available for patients and families themselves to look at their own symptomatology and their need for further evaluation. For example, on the CDC website, there's a screening tool for women with menorrhagia to identify those who may benefit from further evaluation of a potential bleeding disorder. There's also a new app developed by HFA, which is a very interesting app that I have just become familiar with, and that is a way of keeping track of both menstrual bleeding, other types of bleeding, and other aspects of symptomatology. And these latter two apps can be used by individuals to keep track of their own bleeding so that they can then inform their healthcare providers about what their experience has been and document for them the experience that they have with bleeding symptoms, and that may be very helpful in making the diagnosis. And while we look a great deal at women with menorrhagia when we're talking about von Willebrand's disease, we have to remember that both males and females are affected with it. And there have been 2 studies done at the same institution looking at people with type 1 von Willebrand's disease, both males and females. And you can see from this table that there are some differences in the frequency of symptoms. For example, simply in the terms of epistaxis or nosebleeds, males tend to have them more frequently than females. The bruising and dental bleeding and surgical bleeding are about the same. Men have been reported to have hemarthrosis and muscle bleeding, although women were not, I think, asked that question in the survey. 93% of type 1 von Willebrand's women have menorrhagia, and a smaller number have postpartum hemorrhage, although that does occur more frequently in some of the other subtypes of von Willebrand's disease. 11% of males with von Willebrand's disease type 1 had post-circumcision bleeding. And about a quarter of these type 1 patients had required transfusion. And there's an interesting difference in their age at presentation, whereas symptoms developed in 50% of females by the age of 12 and 50% were later. 76% of males had symptoms by the age of 10. And it's often been said that males develop symptoms earlier, and they may be more prone to have injuries in sports and things like that. And that women may not be recognized until they start their menstrual periods. So we can see some difference in the symptomatology, but that the symptoms that are most significant tend to occur in both sexes. Family and history may be informative in von Willebrand's disease. It's an autosomal trait with both males and females transmitting and both males and females affected, but it may be dominant or recessive. On the left-hand side, in the autosomal dominant inheritance pattern, you can see vertical inheritance with presence of affected individuals in several generations. And one of the key distinguishing features to distinguish von Willebrand's disease from hemophilia or autosomal dominant inheritance from X-linked is the presence of male-to-male transmission, because men can't pass on to their sons a bleeding disorder in hemophilia, but they can in von Willebrand's disease. And then on the right, you see the autosomal recessive form that has horizontal inheritance, or it's seen in sibships. And the double line at the top indicates consanguinity, or mating of relatives, because that's more common in autosomal recessive disorders like type 3 von Willebrand's disease. And so that's the patterns may be different depending on the type of von Willebrand's disease that's present in the family. The bleeding may be common among relatives of both sexes, and with family members often called free bleeders. The family members themselves may not recognize the bleeding as abnormal because so many of their family members have nosebleeds and heavy menstrual periods. So it's important to ask specific questions about symptoms, about any early deaths in the family. Ask specifically about consanguinity, which is more common in some ethnic groups than others. but the family history may be negative due to lack of information in the family, the non-penetrance of the gene, which is well known, or the presence of a new mutation in an affected person. So I'm going to go through the types briefly with their clinical features. Type 1 von Willebrand's is known for its high variability. It varies among families, within families, and even within the same individual over time. It may appear to skip generations due to reduced penetrance of the trait. And this type may be treated with DDAVP or STIMate depending on the mechanism, whether it's clearance or lack of synthesis, and also what the severity of the treatment is, of the incident that's requiring treatment. It's notoriously difficult to diagnose, and as I said, is not always due to a defect in the von Willebrand factor gene, so gene testing is not particularly useful. Type 3, the other quantitative defect, has severe bleeding, as I said, including hemarthrosis in some cases, and for this reason it may be misdiagnosed as hemophilia. It requires specific treatment to replace von Willebrand factor, not just recombinant factor VIII or DDAVP alone. It's, as I said, autosomal recessive with frequent consanguinity and may develop antibodies or inhibitors. Type 2A and 2M von Willebrand's disease are very similar clinically. Type 2 patients tend to have more significant bleeding than type 1. These patients both have a low ratio of von Willebrand factor activity to von Willebrand factor antigen and decreased aggregation of platelets-rich plasma with bristocetin or bristocetin-induced platelet agglutination. Type 2A has loss of high molecular weight multimers, where type 2M has normal multimers. In type 2B von Willebrand's disease, there's a gain-of-function mutation which causes increased binding of von Willebrand factor to platelets. And this may present with thrombocytopenia due to in vivo platelet aggregation, often seen in infants. Decreased high molecular weight multimers are present due to binding of the multimers to the platelets. And increased thrombocytopenia may be seen with DDAVP, so it's usually contraindicated. These patients have increased RIPA with low bristocetin concentrations and also have more significant bleeding than seen in type 1 patients. Type 2B has to be distinguished from platelet von Willebrand's disease, which is a gain-of-function mutation in the platelet receptor, the GP1B alpha gene, and this is caused by decrease in high molecular weight multimers due to binding of normal von Willebrand factor to abnormal platelets. And this may be distinguished from 2B by measuring von Willebrand factor binding to normal platelets or by doing mutation analysis. And it's important to make this distinction because the treatment is different, since 2B is a von Willebrand factor defect while platelet von Willebrand's disease is a platelet defect. Type 2N von Willebrand's disease, often called type 2 Normandy, is one of the newest variants identified. It is characterized by reduced factor VIII, but normal levels of von Willebrand factor and normal von Willebrand factor function. In this, it mimics hemophilia or the carrier state, but it can be distinguished by its different inheritance pattern. And it is usually autosomal recessive, but it may occur in combination with other von Willebrand's disease types, making the diagnosis more complicated. This type also requires specific treatment to replace von Willebrand factor, and recombinant factor VIII or DDAVP is not satisfactory in this diagnosis. The testing criteria to determine which patients might need a diagnosis distinguishing type 2N von Willebrand's disease are hemophilia patients who may show a mild or moderate decrease in factor VIII but have no X-linked inheritance pattern in their family. There may be the presence of affected females, and they may have a poor response to recombinant factor VIII alone. In von Willebrand's disease patients, This type may be distinguished by having a factor VIII significantly lower than the von Willebrand factor antigen and von Willebrand factor activity. And now I'm going to talk about the specific tests and how they might be used to make the diagnosis. Screening tests are not very helpful in the diagnosis of von Willebrand's disease. They're used primarily to rule out other disorders. And all of them tend to be normal except in occasional circumstances. The PTT may be abnormal only if the factor VIII is decreased sufficiently. The platelet count may be abnormal in type 2B von Willebrand's disease. The platelet function analyzer, PFA, is often abnormal, especially in type 2 and 3 von Willebrand's disease, but it's not usually considered to be good enough to screen out those people who need to have a test. So usually we use the screening test along with the history to determine whether diagnostic tests for von Willebrand's disease need to be carried out, and they may often be carried out as part of the initial diagnosis since the screening tests are not useful. The diagnostic tests for von Willebrand's disease that are available in many locations include the von Willebrand factor antigen, the von Willebrand factor activity that may be measured in 3 different ways, the ristocetin cofactor, non-ristocetin tests of activity, and collagen binding, and the factor VIII activity. Von Willebrand factor antigen measures the amount of von Willebrand factor protein that is present, whether it's functional or non-functional. Its methods are an ELISA or a latex bead immunoassay. Von Willebrand factor may be elevated as an acute phase reactant. It may be elevated in pregnancy, and it is elevated in African Americans. Von Willebrand factor activity is measured in several different ways, and there's a new classification of von Willebrand activity tests that's been published recently in the journal Thrombosis and Hemostasis. Traditional ristocetin cofactor has been the most used test. The availability of a G1B binding test more recently, but still ristocetin triggered. And then have been added gain-of-function mutant GP1B binding tests that do not require ristocetin. And there's also a monoclonal antibody binding test. The use of ristocetin has been around for many years to look at von Willebrand factor activity, but it has become apparent very recently that some people have a sequence in their von Willebrand factor gene, a normal polymorphism that prevents the binding of ristocetin to their von Willebrand factor and limits the activity of their von Willebrand factor in these kinds of tests. This particular polymorphism does not cause any bleeding symptoms. It's just an artifact that influences the test. But since it's present in 19% of Caucasians and 62% of African Americans, it's definitely a problem for diagnosis of von Willebrand's disease. So while the traditional methods of using ristocetin are still the ones that are most readily available, they have to be considered carefully when we're making the interpretations. The ristocetin cofactor is the traditional diagnostic test for von Willebrand's disease, the one that's usually the most often abnormal. It uses whole platelets. It's also used for monitoring treatment with von Willebrand factor products, but it can be falsely low in African Americans due to the presence of the SNPs that limit binding to ristocetin. It's measured by aggregometry and more recently by automated methods on several different instruments. Ristocetin-triggered GP1B binding has been added that uses a recombinant protein that's a piece of the receptor rather than using whole platelets, and that can be attached to either latex beads or magnetic particles, improving the assay. However, the non-ristocetin-based tests are becoming more important, and people will be going to these methods as soon as they are available in the United States. The gain-of-function mutation that I mentioned does not require ristocetin. It may be able to distinguish types 2A and 2B. and it's being produced by Siemens, but it's not yet available. There's another company that has the test under development as well. Until those tests are available here, the only non-ristocetin-based test is a test for monoclonal antibody binding. It's not really a functional assay, but it correlates relatively well with ristocetin cofactor in most patients, except those that are African American, in which it overcomes that effect of the ristocetin defect. It's usually done by a latex bead assay, but it's not really an activity assay since it's using an antibody, but it may be the best thing that we have at the moment until we have available non-ristocetin-based tests. Collagen binding is a very good test for, it measures a different function than ristocetin cofactor, the binding to collagen. However, it's very dependent on the type of collagen used in the collagen-coated plates. Its ratio with von Willebrand factor antigen is very useful for identifying type 2. And there are specific collagen binding defects in type 2M, but this is not widely available in the United States, and the types of collagen vary, as I said, so its utility is not clear-cut. Factor VIII activity is decreased secondary to the von Willebrand factor decrease because there's not enough von Willebrand factor to carry it. An increased ratio of factor VIII to von Willebrand factor antigen tends to indicate decreased von Willebrand factor synthesis, while a decreased ratio is the only defect seen in type 2N von Willebrand disease, which may lead it to the misdiagnosis of hemophilia, as I said. The most important measurements for classifying von Willebrand disease into its subtypes are two ratios: the ratio of von Willebrand factor activity to von Willebrand factor antigen, and the ratio of factor VIII activity to von Willebrand factor antigen. And these are used to determine the need for further tests that I refer to as classification tests. And these include von Willebrand factor multimers, ristocetin-induced platelet aggregation, binding of factor VIII to von Willebrand factor, which is specific for 2N von Willebrand's disease, von Willebrand factor binding to platelets, which is specific for 2B von Willebrand's disease, mutation analysis of the von Willebrand factor gene, and the newest added test, the von Willebrand factor propeptide. Von Willebrand factor multimers are a measure of von Willebrand factor structure. It's a separation of the von Willebrand factor in agarose gels and then staining with an antibody to von Willebrand factor. They're very difficult to reproduce and not widely available. They may also be abnormal in platelet von Willebrand's disease and in acquired von Willebrand's disease, so they don't distinguish those disorders. Types 2A and 2B von Willebrand's disease can be distinguished from normal individuals by the presence, by the loss of high molecular weight multimers, and this can be quantitated by densitometry of the gels now. Ristocetin-induced platelet aggregation measures the interaction of the patient's own platelets with the patient's von Willebrand factor, and is also abnormal in Bernard-Soulier syndrome and platelet von Willebrand's disease, both of which are platelet receptor defects. It also may be falsely reduced in African Americans because it's ristocetin-based. The ristocetin-induced platelet aggregation in normal individuals is evident at higher concentrations of ristocetin and gradually declines, whereas in type 2A von Willebrand's disease there's little aggregation to very high concentrations of ristocetin. In 2B, the lowest concentrations of ristocetin produce aggregation, even those that do not induce aggregation in normal individuals, and this is a demonstration of the gain of function defect in this particular disorder. As I mentioned, there are two binding tests that are used: the factor VIII binding to von Willebrand factor, which is using recombinant factor VIII to bind to von Willebrand factor, and is a commercially available test that's specific for type 2 and vWD. VWF binding to platelets measures the binding of the patient's VWF to normal platelets, and it's often used to follow up on an increased low-dose RIPA. It determines whether the defect is caused by the platelet or the von Willebrand factor, so it will distinguish 2B and platelet vWD. It's not commercially available, but it's available from reference laboratories. Mutation analysis in von Willebrand's disease, while we were quite hopeful about its advent, has not proved to be as useful as we had hoped it would be. Sequencing of particular regions of the von Willebrand's gene is very useful in the type 2 variants. For example, many type 2A, 2B, and 2M mutations are in exon 28 and can be distinguished in that way. Type 2N mutations occur in the factor VIII binding region of the gene, but type 1 and type 3 mutations could be at any location. And because this is such a large gene, using mutation analysis to clarify the diagnosis of type 1 von Willebrand's disease, however, is not particularly useful because it requires a great deal of analysis to study the entire gene. Also, von Willebrand factor mutations are present only in about 65% of type 1 individuals. About 35% don't have any recognized mutations in that gene, and other genes have not been identified yet to study. The type 1 mutations are actually correlated with low levels of von Willebrand factor, families that tend to have levels below 30%. And these are often characterized now as having definite von Willebrand's disease, if their levels are quite low and a type 1 mutation can be identified. The newest test is the von Willebrand factor propeptide, which is a small piece of von Willebrand factor that's dissociated from the mature von Willebrand factor protein after its release into the circulation. And normal individuals have the propeptide present in equal amounts with the von Willebrand factor antigen. When there's an increased ratio that is more propeptide than antigen, it indicates that there has been increased clearance of von Willebrand factor. An increased ratio correlates very well with the presence of a mutation in type 1 von Willebrand's disease with a positive predictive value of 98%. And it also has recently been shown in the references that I've cited to distinguish type 3 patients who really have no von Willebrand factor synthesis and null mutations from those who produce a von Willebrand factor that is extremely rapidly cleared, and those may be classified as severe type 1. It's likely that based on some of this newer information about the mechanism involved in types of von Willebrand's disease, that there will be a change in classification over the next few years to eliminate the reliance on multimers as our distinction in terms of identifying subclasses to perhaps go on to tests that can be more readily applied in clinical laboratories. Okay, now this is a table that I have taken from the NHLBI guidelines produced in 2006 by a panel of experts on recommending diagnostic procedures for von Willebrand's disease, and these are expected laboratory results in various subtypes. And you'll note in the first line that for type 1 von Willebrand's disease, the scheme suggests that type 1 von Willebrand's disease be diagnosed in those with levels below 30% for ristocetin cofactor or for von Willebrand factor antigen. And this is considered to be definite von Willebrand's disease. There's quite a bit of disagreement over this requirement for a very low level, although it can be said that this is the level that does correlate with the presence of mutations. Some people, however, have levels in the range of 30 to 50% of von Willebrand factor antigen and ristocetin cofactor, and they do bleed. The NHLBI guidelines have classified those further down the table as those having low von Willebrand factor, but not necessarily von Willebrand's disease. But they have specified very clearly that it's appropriate to treat people with low von Willebrand factor who do bleed, whether they receive the label of von Willebrand's disease or not. So as I said, there may be some clarification of classifications later, but this is sort of the accepted terminology right now in the United States. Type 3 von Willebrand's disease in the second row results in very low levels of von Willebrand factor and low levels of factor VIII due to lack of von Willebrand factor to carry it. And that von Willebrand factor VIII in type 3 von Willebrand's disease is usually less than 10%, but not totally absent, while the other proteins that we can measure are absent, the other von Willebrand factor related measurements. And then 2A through 2M are those that have decreased ratios of ristocetin cofactor to von Willebrand factor antigen, because they have von Willebrand factor antigen, but it doesn't work normally. Some of those have abnormal multimers and some do not, but it is the ratio that is often used for distinguishing those. And 2N is the one that mimics hemophilia. There are also a number of other variables that have to be taken into account in making the diagnosis of von Willebrand's disease, particularly in type 1, where we're looking at levels rather than a qualitative defect that we can measure in some other way. Some of them are physiologic. Age, von Willebrand factor increases up to 1% per year. So you may see that there are evidence of patients who now have a normal von Willebrand factor level, but may have bled very badly when they were younger. We know that von Willebrand factor is affected by estrogen in the menstrual cycle. Von Willebrand factor is lowest during the menstrual period, and that may be the time that's best to test for some patients who have fluctuating levels. Oral contraceptives have caused increases in von Willebrand factor in the past, but most current formulations do not alter von Willebrand factor levels, and it's not usually necessary to ask patients to stop taking oral contraceptives for testing. In pregnancy, the levels rise pretty dramatically till the third trimester, but they may drop rapidly also immediately postpartum, and bleeding may occur in the first few weeks after delivery, but not immediately. There also are obviously other genes involved that will influence von Willebrand factor levels that we don't understand yet. The best known influences are the ABO blood group, which accounts for a large percent of the total variation in von Willebrand factor, and race, which causes a difference that is not thoroughly understood today. The ABO blood group differences apparently result from increased clearance, in that the propeptide to antigen ratio is increased in the blood group O individuals, suggesting a clearance difference. The race differences cause African Americans to have much higher levels of von Willebrand factor than Caucasians and other ethnic groups, but the ristocetin cofactor is not affected in this change because of the ristocetin SNPs that we've talked about. If you look across at the tests in the first panel, the antigen, the collagen binding, the monoclonally detected von Willebrand factor activity, and the factor VIII, all of these show dramatic differences between ethnic and blood type groups. So you see that in type O Caucasian individuals, the means are around 70 to 90%, while in non-O African Americans, they are in the range of 120 to 140. So there's a dramatic difference. This has not currently been recommended to be taken into account in making the diagnosis of von Willebrand's disease, but that's not thoroughly determined yet whether it is necessary to include this. If you look at the ristocetin-based test in the lower panels, they don't follow the same patterns. They have differences depending on race and blood group. Other modifiers of von Willebrand's disease include the pathologic modifiers of inflammation, malignancy, and vascular damage, all of which tend to release von Willebrand factor or cause it to act as an acute phase reactant. Autoimmune disease may also cause an increase in von Willebrand factor. Thyroid dysfunction, however, may cause an acquired von Willebrand's disease due to lack of synthesis. And this is a very complex flowchart that I've put together on the diagnostic process for von Willebrand's disease. And I'd like to walk you through it a little bit and hope that you can refer to our recorded presentation later to look at it more in detail. It starts with, in the first level, the demonstration of a decreased von Willebrand factor antigen or von Willebrand factor activity or factor VIII. Now, von Willebrand factor activity measured by any of the methods that we've talked about, although the ristocetin-based tests are more questionable. But to look at the diagnosis, you have to measure both ratios and look at both at the same time. If you're looking at the ratio of von Willebrand factor activity to von Willebrand factor antigen, there's a cut that's usually, for most labs, around 0.6 or 0.7. And people who have a normal ratio of von Willebrand factor to antigen can be presumed initially to have type 1 disease. It's recommended that you go ahead and do multimers after you make that presumption because multimers may show you that your ratio could have been wrong if they're abnormal, and it's worth considering that because of the differences in treatment. So, but the presumption can be made initially that you're dealing with type 1 disease. If the multimers are normal, or there are occasionally some very rare defects that most labs can't pick up, you're dealing with type 1 von Willebrand's disease or low von Willebrand factor. As I said, if the multimers are abnormal, then you may go back and reevaluate the possibility of type 2. But in general, there will be a reduced ratio of von Willebrand factor activity to antigen in type 2 defects, and those multimers will then determine whether the presence of normal multimers indicate type 2M disease. Abnormal multimers are the other type 2s in which you are required to do RIPA. The result of the RIPA indicating whether we are dealing with 2B or 2A. So there's a stepwise diagnostic process, and I put in the step to make a presumptive diagnosis in the middle because most labs can't provide all of these tests to determine all of these subtypes immediately. There will be some time delay in getting multimers done or getting the results of some of these other tests, and it's very important to be able to at least make a presumptive diagnosis so you know how to treat in the meantime while the diagnosis is being worked out. If the factor VIII to von Willebrand factor antigen is the only defect, if it's less than 0.6 or 0.7, then you're dealing with type 2N von Willebrand's disease or hemophilia A. And whether you're dealing with one or the other may be evident from the inheritance pattern in the family or the symptomatology, but the distinguishing test for determining whether there's a difference, what the different defects are, is the von Willebrand factor VIII binding, which is available from some reference labs. We recently did a study on von Willebrand factor in patients that we were following in a study of hemophilia A. We found 37 patients not to have any mutation in the factor VIII gene, even though they had hemophilia A, so we questioned whether that was really their defect. And when we looked at those, there were 11 that were severe and 26 that were non-severe. And then we looked at a group that we did determine the factor VIII mutation in as controls. And we found 4 patients that have been misdiagnosed as having hemophilia when they really had type 3 von Willebrand's disease. And those 4 were determined to have factor VIII mutations. When we looked at the category of those that had definite von Willebrand's disease or evidence of type 2, we didn't find any of those in the group with the negative for factor VIII mutations. We found 1 in those with mutations. So we found 1 patient with factor VIII mutation and a von Willebrand factor mutation, which is seen relatively commonly in families. In looking at the low von Willebrand factor levels, we found those in 5 of the ones who had no mutation and 4 of those who did. But among those 9 patients, only 1 of those could be confirmed to actually have a mutation in von Willebrand's disease. But we think these findings are striking and important because if a patient is misdiagnosed as hemophilia when they really have von Willebrand's disease type 3, then recombinant factor VIII is not going to be appropriate for their therapy. And of these 4 patients, only 1 was receiving a product that contained von Willebrand factor and factor VIII. In the case of those with another subtype of von Willebrand's disease, or just with low von Willebrand factor, there may be an influence on the recovery and survival of factor VIII based on how much von Willebrand factor is present. So the concomitant presence of von Willebrand's disease should also be considered in patients who don't respond well to recombinant factor VIII, because potentially they may have low von Willebrand factor. So the differential diagnosis for von Willebrand's disease includes, as I've said, the mild or moderate hemophilia, hemophilia carrier state in women, the rare factor V and VIII deficiency, platelet function disorders, and acquired von Willebrand's disease. Distinguishing hemophilia and von Willebrand's disease is relatively simple if one does a panel of tests, in that the only abnormality seen in hemophilia A is decreased factor VIII, and inheritance pattern is usually X-linked, while the other defects may be present in von Willebrand's disease in a variety of tests that can be performed. The other disorders are much rarer. Combined V and VIII deficiency results in factor V and factor VIII decreased to about 5 to 30%, and it's an autosomal recessive. Bernard-Soulier is a platelet function defect that can cause reduced RIPA, but the patients have normal factor VIII and von Willebrand factor. And acquired von Willebrand's disease may be suspected in patients without lifelong bleeding. Those that have a history of bleeding throughout their lives are not usually considered for this diagnosis. The mechanisms of acquired von Willebrand's disease include the absorption of von Willebrand factor onto cells or surfaces in the body, the presence of antibodies to von Willebrand factor, or decreased synthesis. And examples of that are lymphoproliferative disorders in Wilms tumor, where there's absorption of von Willebrand factor onto cells, and congenital heart disease, where the abnormal heart surface is under shear stress absorb von Willebrand factor multimers. In autoimmune disease, there may be production of antibodies, and in hypothyroidism, there may be decreased synthesis. A lot of acquired von Willebrand factor, other than those due to the tumors and congenital heart defects, tend to occur later in life. Now, you may be wondering how you're supposed to do all of these complicated tests in the laboratories that you're dealing with in treating patients. And it's very important that you recognize that not every laboratory is going to have all the capabilities to make these diagnoses. As I said at the beginning, most of the patients you're going to be dealing with will have type 1 von Willebrand's disease, but it's important to identify the other subtypes to be able to correctly treat those patients who have qualitative differences in the von Willebrand factor. But it may take longer to get the diagnosis made, and it may be more complex. And I would like to call your attention to the availability of commercial reference laboratories for testing for von Willebrand's disease. There are a number of high-quality labs that provide panels of tests, including both reflexive panels where they will make the choice of tests based on the results. There's mutation analysis available of some types in certain labs. So you have resources and that you can call on for diagnostic testing to provide those that your hospitals don't offer. And for many labs, the cost is prohibitive to keep up all of these tests, so they rely increasingly on the reference labs for that. The key factor in using reference labs, however, is getting them the quality specimen. And the NHLBI guidelines have recommendations for collection of specimens and handling prior to testing, which are very important to adhere to, particularly if the samples will be shipped. Phlebotomy needs to be atraumatic and in low-stress situations, which is often difficult. For specimen processing, as opposed to other coagulation proteins, specimens need to be maintained at room temperature for transportation and centrifugation for von Willebrand's disease diagnosis. They should be used or frozen within 2 hours and then thawed at 37 degrees and tested within 2 hours. For storage, they need to be below -40 degrees in a commercial freezer, not a home freezer or refrigerator. They have to be shipped with sufficient dry ice to survive the trip. And a rule of thumb is not to ship over weekends or holidays when the specimens may be delayed. Because in spite of how well a laboratory may be able to do the test, they can't provide quality results if the specimen that they receive has not been appropriately handled and transported. So I'm almost to the end of our time, and I'd like to note for you some challenges and opportunities. The biggest challenge is diagnosing von Willebrand's disease itself with all of the complexity of the testing and the algorithms that it requires to go through. Additional challenges are providing physicians with the education that they need to make the diagnosis accurately and providing access to quality testing so that patients in hospitals all over can be tested appropriately for distinguishing this very common disease. It's also very important to educate patients about their disease. As noted, there are some self-help apps and things to help patients understand, but one of the key variables is it's very important to educate the patient about the particular form of von Willebrand's disease that they have. A type 1 patient does not need to understand all the intricacies of diagnosing type 2 von Willebrand's disease. They want to know about their disease. And if we can provide very specific information to patients about that is geared to their particular situation, we will do them a better service than providing a complex diagnostic and explanation about all of the tests and features that apply in all cases. And I think the organizations working with bleeding disorders are making a lot of steps forward in trying to do this education process, and we applaud their activities. There are opportunities. There are opportunities to improve the diagnostic test for von Willebrand's disease through utilization of new findings in the clinical test, such as the propeptide, and in revising classification to make it simpler to understand what's going on in the different disorders. There are the possibilities to investigate other influences on von Willebrand factor function, such as glycosylation, which could be measured clinically, but we have no handle on right now. And then it's important to identify the other genes involved in von Willebrand's disease, type 1, so that we could truly provide a genetic diagnosis to clarify in more patients than we can now. And in conclusion, I would like to thank the Hemophilia Federation of America for hosting today's webinar. They've been very instrumental in getting this ready for us and getting this on the air, and we're very appreciative. We would like to put in a plug for our next webinar, which is coming up on World Thrombosis Day, and will be on the prevention and treatment of venous thrombosis during pregnancy by Dr. Andrew James, and that will be on October 13th at 2 p.m. My contact information is available, and I welcome questions after this for anybody else who has any that we didn't address today. I'd be happy to receive your emails and respond to you. Thank you.
Thank you, Connie. That was a very clear presentation of what can seem a very complicated bleeding disorder, for sure. At this time, we have time for a few questions at least. I'd remind the audience that you can submit your written question if you haven't had a chance. For Dr. Miller, just use the questions area of your toolbar. While we wait for that to pop in, Connie. There was one striking point, if I can sneak a question in, from your presentation that I thought I'd ask you about. And that's about the variability of the disease, the high variability of the disease that happens even within families. Could you comment a little bit more on that and what's known about the how or why this occurs?
Yes, von Willebrand's disease is an autosomal dominant disorder. And what we know about autosomal dominant disorders is they're often due to structural proteins. And they're often due to structural proteins made up of subunits. And that we often find variability in these types of disorders because when you have both normal and abnormal subunits, how many of those are combined may often influence the result. For example, if one person has a larger amount of their protein with abnormal subunits, they may be more deficient than someone who maybe by chance has more normal subunits in the protein that they're making. And while we don't understand exactly how that happens in von Willebrand's disease, there have been some recent studies that have demonstrated within families that that does appear to be the case, that you can look at different family members and see that some of them have a more abnormal protein than other family members due to this subunit difference. And I think that that's clarifying for us a little bit about why we see some of these differences. But although we don't yet know how to, what the control mechanism is, at least we're getting to the point of understanding why we see differences from individual to individual.
Great. And I see that there's a question from the audience too, asking which particular one test would you recommend first for diagnosing in African Americans after the screening test supporting vWD?
The tests that are most useful in diagnosing von Willebrand's disease have always been the activity assays, and a few years ago we would have said ristocetin cofactor was definitely the best method, but since we now know that it is abnormal in many African Americans, I would recommend a test of activity that does not involve ristocetin, either the monoclonal antibody test that's available or collagen binding for measuring that. Very often the von Willebrand factor antigen will give you the answer that you seek, because if it is low, you're usually dealing with type 1 von Willebrand's disease regardless of what your activity assay shows. So I would do an activity assay not involving ristocetin and an antigen assay to most clearly make the diagnosis. And we're hopeful that some of these better assays may be coming along and become available to us shortly.
Great. So I think we're a little shy on time, but I think we have time for one more question. And this is from the audience as well. And they're essentially indicating that they have von Willebrand, VWF, and a factor, I think they're saying a factor 11 deficiency, but they've never been told there were different versions, and should they ask at their hospital which type they have specifically?
I think it would be useful to ask because it should influence their treatment, and the reason they may not know is because they may not have one of the rare types that requires a different kind of treatment. Type 1 von Willebrand's disease and factor 11 will be somewhat similar in their presentation, and it may not be clear that there needs to be differences in treatment. So I think that it may have been handled as sort of one condition over time, but I think it's important to know the type and to ask the question of whether their von Willebrand's disease needs to be treated in a specific way because of the type they have that might be different from how their factor 11 deficiency might need to be treated as well. So I think it's worth asking the question. And I think it's, there are a number of people that have von Willebrand's disease in conjunction with something else. And that also accounts for the variability, and it's important that people know if they have more than one disorder and that be addressed.
Okay, well, thank you, Dr. Miller. Again, I'd remind everyone these presentations will be archived and will soon be available. at both the Division of Blood Disorders and the Hemophilia Federation of America's websites. And finally, just one last note, please